yells, obscenities. Crew let patient do this during transport. Patient doesn't want to be touched. Now, what is the misconception? Somebody reading this cold. I wasn't on the call. I wasn't out there at 2:30 in the morning. I didn't feel the cold, chilling rain on my bones. I'm not tired when I'm reading it. What's my perception when I read something like this?
I think it sounds fun.
You think it sounds fun?
To be honest with you, I don't see a problem.
How about this? Crew let patient do this during transport. Patient doesn't want to be touched. Now compare that with patient found in parking lot after fight with laceration to head. Now, how much force does it take to get a laceration to your head? So is the patient yelling obscenities and we're just letting him do that and he doesn't want to be touched because of the head injury or because the patient's intoxicated? Now I'm just letting him be 3:30 in the morning. So what the question will be is, well, so-and-so paramedic, you do know that a patient could act differently when they experience a head injury, right? And some of those things or mannerisms that they display while they have the head injury, you may perceive that the patient's being intoxicated. Washington, D.C. settled a huge lawsuit based upon this. Right? A huge lawsuit. It just happened to be a New York Times reporter that fell down, had a head injury. They made the assumption he was drugged. No treatment, didn't take him to a trauma center. Right? Why? Because they had a sarcastic patient care report. They had an anchoring bias that the patient was drunk, and they did nothing to rule out the head injury. I don't have a CAT scanner in the back of any of the medic I'm on. Maybe Ohio Health will build one at some point, put one in the medic, and we can drive around the city. But that's kind of a joke too. Global health.
Yeah. That one we got.
Okay. But I have certain tools as a paramedic. And what this kind of sarcastic snippet shows is I may not use those tools because I've made an assumption the patient's intoxicated and not ruled out that the patient has a head injury. So what I probably should do is document those things that I should document because I do the assessment the right way rather than make that assumption. So this not only reflects my sarcastic and maybe standoffish approach to an intoxicated patient who gets in a fight at a bar at night, but also maybe my frustration overall with what's going on. And more often than not, I know what I need to do, I'm just failing to do it. So this is a good quality assurance thing. When you see something like this, when it doesn't rule out the head injury, that's a situation where there's probably some room for improvement. Pertinent negative, right? It's a finding that is relevant based upon the complaint, patient's complaint, the assessment, or the treatment you administered or did not administer. So before I read this out loud, do you guys backboard all patients involved in a? Okay, so there's certain things that say when it's appropriate to backboard a patient and when it's not. Okay. Now this is just general stuff here, and I kind of gave the answer why I was going to ask, but that's fine. 47-year-old male tripped and fell, denies hitting head, loss of consciousness in head, neck, or back pain, denies drug or ETOH use, alert and oriented times 4, communicates well, follows command, PMS positive, no focal neurological deficit. So would it be appropriate that this patient is not put on a full spinal motion restriction?
Absolutely.
I basically went through as restrictive of a policy and procedure on backboarding patients as you can be with actual facts that I observed, not a conclusion that patient doesn't need SMR, right? Now, here's an example, focal neurological deficit. If it's in my protocol, and I don't know what that is, but it's something that triggers whether I do a treatment or not do a treatment, I probably need to know what that means. These lists are long. And if the list for focal neurological deficit is too big and I really don't understand it and how it fits within it, the protocol, then I probably need to ask my medical director or the EMS protocol committee if we can tailor that and narrow it down so I can remember it in 3 to 5 minutes. I just use that as an example that sometimes in our protocols there's words that we don't know what they mean or how they apply. Right? So we can't just make the assumption. My mom said never to assume.
Can you abbreviate that? Because I put no deficiencies found, or no deficits found. being more specific to neurological.
Well, I base this off the Greater Miami Valley protocol. In that protocol, it says between 3 years old and 70 years old, if they have no drug or ETOH, no loss of consciousness, and they have no focal neurological deficit. The Columbus Division of Fire's protocol is different than the Greater Miami Valley. So it doesn't actually use the term no focal neurological deficit, but it lists like 12 factors when it's okay not to backboard a patient. So I think it would be important that it aligns with what your treatment decision is. So if your protocol says the patient has to have no numbness, tingling, vision loss, hearing disturbances, basically no focal neurological deficits, then you put no deficits, X, Y, and Z. And that does a couple things. One, it lets whomever's reading that know that you actually checked all those things. And here's the reason why I think that's important. Sometimes folks get in the habit of putting breath sounds bilateral, clear, and equal. And they didn't walk into the building with the thing that carried the stethoscope. So how did you know breath sounds were bilateral, clear, and equal? Because you just get in the habit of clicking. Or they say, and that's the one thing that I hate about check boxes and pull downs. It's easy just to click. When we had to write everything out, when I first started, you really only wrote out what you did because you didn't have something there prompting you to answer the question. So I think it's important to write that out, because what if one of those things develops later on? Or you didn't check one of those things, somebody else checks it and it's there. But I'm not the author of your report, so if you can get the picture, no deficits from the other check boxes, that's great. Because remember, the narrative just ties everything together, and what I'm doing here is trying to give a full picture without a full patient care report, because we don't have all the time for that. Any questions about pertinent negatives, sarcasm? Adjectives. I think it's important to show the reader, not tell them. So that's the theme, right? Show not your conclusions, but the circumstances that you encounter, right? Circumstances, not the conclusion. So patient angry. Angry is an adjective, it's a conclusion. Patient uses profanity directed at bystander on scene. Patient involved in fight with bystander. Patient does not follow commands or answer assessment questions. Now that's pretty clear as to that the patient's probably angry or delusional or needs a psychiatrist or something. But it tells me in a very respectful, objective way, right? The patient was yelling, they were profane, they were in a fight, they weren't doing what I was telling them to do. A little bit different than that sarcasm thing. The patient didn't want me to touch him. Right? The patient just yelled at me the entire time. I'm actually giving objective facts in a professional manner that can tell anybody down the road what this patient was like when I first encountered him. So we have to, I think it's important, stray away from the conclusions, focus in on the circumstances that we encounter. The same thing applies to fire reporting as well. Right? If you show up, if you think about it, and you do a scene assessment or a scene survey or scene assessment or something, you get on the radio, you say we have a working fire. You don't just say we got a working fire. Right? You usually say got smoke coming out from the A, B side, Division 2 or second story of a multi-unit residential structure. Right? Hydrant in front of the structure. But we haven't applied that over to the EMS side. Probably because it's right. We don't think it's as crazy or as exciting or whatever else. But we don't show up on the fire scene and say we got water and a fire. We're good. So we can't just rely on conclusions. We have to use the circumstances to lead people to that. Refusals. Everyone I've ever talked to is scared to death of refusals. I think that's where most of the liability results. I read EMS lawsuits all the time. The vast majority of lawsuits, and I don't have an exact percentage, are not based upon refusals. Right? They're just based off of bad EMS. And the number one thing that's bad is that the EMS providers fail to do a complete or a proper assessment of the patient. Right? Remember, our patients have to have informed consent before they refuse care. Right? Informed consent. That means they have to know and understand the consequences of their actions. So I have to tell that patient, hey, if we don't go to the hospital, these are things that could happen. If we go to the hospital, this is the benefit of it. But if I don't know and understand as the EMS provider, how can the patient know and understand? So in order for the patient to have informed consent, I have to do a complete assessment. And then I have to document that assessment. So here's our example. 64-year-old female complained of weakness times 3 days. What is the most important assessment to do on this patient?
Stroke test.
Blood sugar.
Neurologic, blood sugar, there's a lot.
Yeah, so I guess not some of the most important. So stroke test would be one. Blood sugar.
Sepsis.
What?
Septic.
Yeah. What's her
Well, they
skin
weren't
temperature?
sugar oriented or
Cardiac.
Cardiac.
Yeah.
And specifically, what type of cardiac assessment? And the AHA has been hitting this hard for the last 3 years. Females over the age of what, 35 or 40, I think, complaining of weakness times multiple days, need to have a 12 lead. You do a 12 lead, and here's all your stroke test is negative, patient's skin is not red, and she's not septic, so she doesn't have a fever. That's a very basic thing to rule out sepsis, but it's not sepsis. You do a 12 lead, you see a normal sinus rhythm, no elevation in any leads. Blood pressure is 120 over 80, sugar's 95, alert and oriented times 4, follows command. Okay, she just says, I don't feel right. So you've done everything. How do you inform the patient of the situation? So first and foremost, what does that 12 lead look for?
Damage occurring right now.
It looks for a STEMI. But we could have a non-STEMI. And the only way we tell that in our paramedic brains is if we do what? Go to the hospital. So we've checked you out for the stuff that we can check you out, ma'am. But there's some things that we can't do. We can't check out, we can't draw your blood right now and run some cardiac enzymes. The only place they can do that is the hospital. If we take you to the hospital, they'll be able to either rule that out or determine if that is the problem. If you stay here, the problem may get worse. And one of the biggest things we haven't done in EMS is understand that there are limitations to what we can do, right? Because if people don't know what to do, what number do they call? Easiest one in the world, 911. So we've absorbed this feeling that we can do it all. But we can't. So how can that patient know and understand if we can't? So we can't tell a patient, you're okay because I did a 12 lead, normal sinus rhythm with no elevation. We still have to provide that patient with informed consent because we did a complete assessment, and then we have to document that informed consent on the patient care report. So here's my 3 things that I think for all refusals, patients say they don't want to go to the hospital. One is the assessment. It's got to be the assessment that's indicated by the chief complainer, what you observe or what you encounter. You have to know what the patient's mental status is because the patient has to have the capacity to make a medical decision. Now, EMS textbooks and some medical textbooks use the word competent. In the United States, the only people that really determine who's competent or not are judges and state legislatures when they pass laws. So we determine, does this individual have the capacity to make a medical decision or not? In other words, do they know and understand the consequences of their action based upon my assessment? Are they alert oriented? Do they follow commands? What is their affect towards me? And then finally, informed consent. Right? We advise the patient of whatever the circumstances are that led to it, and that we have limitations. And this is, to me, is a very simple outline, but there's so much fear, and if we don't take them, something bad may happen. No. People have a constitutionally protected right to refuse medical care. Nobody has to go to the hospital if they don't want to.
Gee, why did they call 911?
Maybe they just want to talk to you, right? So let's say you encounter that patient who doesn't want to go, but you say this patient really's got to go. And EMS textbooks or the philosophy that we've always learned is we're going to do what's in their best interest. Well, doing what's in their best interest doesn't bypass the Constitution. Actually, and we are all the government in here, right? So the Constitution protects them out there, the citizens, from our actions. Right? Protects them out there from our actions. It restrains us from barging into somebody's house and making sure they're not hooking a 20 amp heater up to a 15 amp extension cord, right? So if you're going to treat or transport a patient to the hospital, and they've explicitly said no, you know, the flopping around, fight, don't touch me, get away from me, kind of thing. You better document the circumstances that led you to the conclusion that you could violate their constitutional right, and that would be they were a threat to themselves or somebody else, or they lack the capacity to make medical decisions. But we better do that with facts, not just a conclusion. or a threat to themselves. I should put something in there like, patient complained of some suicidal and homicidal ideations. The patient stated there were spiders crawling on the walls, and the patient had placed tinfoil over the windows and all the vents. They were afraid of gamma rays or chemtrails coming into their house. That may be normal in Worthington, but it's not normal elsewhere.
Yeah, well, there's a guy that lives down the street that's got that.
Okay. So that's not, and then we take them to the hospital, they do a much more thorough assessment of us, or of the patient, to determine, does this patient really need long-term mental health care or not, right? Or can it be managed? But we better be able to document the circumstances that underlie these conclusions.
Could I have you go back one?
Yeah. This one or the one before?
One before, where, well, I might even be one before that, but you, oh, yeah, that one. 64-year-old female weakness times 3 days, and we talk here about refusal. However, now, instead of refusal, we have done our assessment, okay? Gone all the way through it, and it is everybody's opinion in the room, medic, patient, everything. They don't really need to go. They'd rather follow up with their own physician, or I don't see anything wrong with you tonight. My assessment shows nothing. It could be something else, but do I absolutely have to take you to the ER? Would it be better if, you know, you would rather go to your private physician tomorrow? You know, so that becomes basically an assessment and a non-transport, but it's not necessarily a refusal.
They call us for
How
like a
do
consult.
you document that differently?
Yeah,
They call us for like a consult. Somebody said, I just not feeling well, I don't know what to
Yeah,
do.
so when I think about this situation, it's the, hey, can you just check me out situation.
Right.
Yeah. Because most people, they're just generally feeling weak. Maybe this is a female that lives by herself in a big house and this and that, whatever. I think that may be more splitting hairs that don't need to be split. Regardless, whatever it is, the patient's in control of their own destiny.
Yeah.
So we can advise the patient of our assessment findings and the risk and benefits of not going to the hospital and waiting a day to go to the primary care physician. But ultimately, it's going to be that patient's choice.
Right, but what I'm getting at is, when do you have them sign a refusal when it was, is it really a refusal? Let's say it's the patient with the flu. You know, I just feel